I'm Sarah Wynick, and I'm a child and adolescent psychiatrist. And I work at the Tavistock and have done on and off since the early 90s, 1991. So I've been here a long time, although not quite as long as our speakers, or two of our speakers today. They got here before me. The way we're going to structure today is that we're going to hear, we, as you know, have 4 speakers, and we're going to hear from them. And whilst they are talking, we're going to turn the chat function off so that we can all focus on what they're saying. Because in my experience, when we leave it on, people then talk to each other as it's going along, and that's quite hard in terms of multitasking, I think, and can be a bit distracting. So the chat function will be off while everybody's speaking, and then when we get to the discussion, we'll turn it back on again, and you'll see you'll have a limited number of people that you can chat to, and what I'd like to suggest is that people ask questions and send them directly to me, because then I'll have them as a list and I will put some of them together, because there'll probably be too many questions for us to take each one individually in the time that we'll have left to us. You'll also at that point be able to put your hands up using the hands up function, not actually literally raising your hand, because I won't be able to see you because there's too many people. So if you would rather ask your question as a speak it yourself with your own voice, then please do, when it comes to it, put your hand up and I'll call on you and you can say your question to the speakers. So just to get going a little bit about what we're doing, we're going to talk a bit about history, and a bit about current practice in our autism team. I, as I said, came to the Tavistock in 1991, and I worked with Sue and Anne in the 90s. And I think, you know, over the last 30 plus years since then, there have been in some ways lots of changes in how we think about neurodiversity, in how we make diagnoses, and treatment. So in some ways there have been lots of changes, but in other ways I think the idea that we're going to be talking about, that therapy can help children and adolescents with autism manage their feelings and their relationship to the world differently and ultimately feel happier as a result, was controversial then, and I think in lots of places it's still pretty controversial now. And so I think it makes what we're describing both something about the development of an applied child psychotherapy technique to meet the needs of a particular population, but also an act of belief and advocacy that, that people with autism shouldn't be left out of something that we think can be really helpful. Mm-hmm. So I just want to introduce our speakers. I'm going to introduce, I think, all 4 of our speakers now, and then they can segue into each other. So our speakers today are Sue Reid, who is a child and adolescent psychotherapist and an adult psychotherapist, who saw her first child with autism in 1970. She founded the Autism Research Workshop here at the Tavistock in 1986, and that led to 4 research projects in this field and the autism team. She is particularly passionate about the importance of involving parents and family in this work. Our second speaker will be Anne Alvarez, who is also a child and adolescent psychotherapist and was the co-convener of the autism service with Sue. She is the author of Live Company, Psychotherapy with Autistic, Borderline Deprived and Abused Children, and with Sue Reid has edited Autism and Personality Findings from the Tavistock Autism Workshop. Myron Kanagaratnam is a consultant child and adolescent psychiatrist in the current autism team here, where he leads the Diagnostic Assessment Clinic. He also runs the training scheme for child and adolescent psychiatrists here at the Tavistock, and is involved in training professionals of all different disciplines in the diagnosis of autism. And our final speaker is Mohammed Pollock, who is a clinical psychologist and psychotherapist with a special interest in the relationship between neurodevelopmental conditions and the socio-emotional environment of the person that she's seeing. Mohammed has worked in the learning disability and autism team for a long time and has also been involved with autism and LD CYPI Act at the Anna Freud. And her main area of work now is with 18 to 25-year-olds with the extra challenges of transitioning into adulthood. So those are our 4 speakers, and I'm going to ask Sue to start us off.
Thank you. Well, when I was invited to speak at this conference on autism, I was delighted to accept and to share with others how I had to learn from my experience. I was most fortunate when, at the very beginning of my training in 1970, I had the unusual opportunity to work with a child with autism, or to be more accurate, as she was called then, an autistic child. Thinking back over 50 years really underlines for me the importance of understanding that ideas must develop. And talking about the autism work at the Tavistock, I want to underline that thinking must and should have changed over the years, which is why I thought it important to say that someone was called an autistic child or poor person, not a person with autism. Now, at the beginning of my training, I'd not even heard of autism. And for many of you here, that must be difficult to believe since there are now so many books, articles, television programs, and so on by professionals, parents, and people with autism. My first post was at an educational priority area school where I was to run psychotherapy groups. When I first met the head teacher of the school, a person, in fact, who had a very strong influence on my development, I was told there was one person I had to put in the group. And this was a little girl whom I will call Anna, who at that point in time was in the nursery and whose behavior, violent outbursts succeeded by complete withdrawal, was a great challenge to everyone. The head feared they might not be able to keep her unless I could do something, so no pressure there. My first sight of Anna had me fascinated. I was greatly supported by her nursery teacher, who gave me a chair to sit on and explained that Anna would almost certainly take no notice of me. I watched fascinated as this little girl did circuits around the nursery, shaking her hands in front of her and stopping every so often to sniff a child's hair, at which point she would either make an approving sound or shake her head. Only by close observation could I see that she was in fact circling gradually closer to me. She had noticed my presence. At some point she stopped in front of me, leaned in and smelled my hair. Fortunately, she gave an approving I was careful not to move suddenly, and without turning my head, I simply said, "Hello, Anna." At this point in my own professional development, I was very much supported by Martha Harris, who was head of the child psychotherapy training. When I told her about Anna, I said I knew nothing about autism, and she, rather non-committally, encouraged me to find out for myself. But what equipment did I have at this point? Two very important things which I value more and more as the years go by. First is our training in psychoanalytic infant observation and young child observation, psychoanalytic theory, which in those days was taught to me, in fact, by Anne, and the support of my seminar. The emphasis in this kind of observation is on going in with an open mind. And here I want to stress, not looking for something, but discovering what is there to be seen. This has stood me in good stead over the years, and I try not to come to the patient with a construct, but to allow the construct to emerge between us. From infant observation, we can learn as adults what in fact we discover ordinarily in development as infants, the importance of non-verbal communication, gesture, body movement, facial expressions, and that eyes are the window to the soul. What else did I learn from my first contact with someone with autism? Several things. First, the importance of a network. Anna's nursery teacher was extraordinarily sensitive and open to sharing her experiences with me. And when I started the group, we had many conversations together. We discovered that what happened in the group impacted on the nursery and vice versa. I also had the support, hard won at first, from the rest of the staff who called me the shrink at the beginning, and of the head teacher. I also discovered that it is essential never to work with a child with autism without being in contact with his or her parents. And with hindsight, I'm grateful for this as an accident, really, because the head of the school insisted that I meet all of the parents of children who were coming into my groups, which was very unusual in that setting and in those times. She added that if they wouldn't come to the school, I had to do a home visit. I was not at all experienced in this. However, I did a home visit, and it opened a window for me on the impact on parents of having a child with autism, something I will never forget. Anna's behaviour was so extreme that she had in fact been referred to the local child guidance clinic, which was unusual in those days and in this kind of environment. Her parents, however, wouldn't agree at that point in time to her going, because they said it was just for mad children. Over time, Anna's behaviour began to change, and her parents started coming to the school, which they'd avoided before, and pausing to have a bit of a chat with me. They told me, for example, that she started to speak and would complain vociferously at the weekends, and she started saying, "Put the weekend in the dustbin, no group." But they were generous enough to share that with me. This led, over time, to an increasingly shared cooperative journey with parents, with me, with the nursery teacher, and with the school as a whole. Her parents started coming to school assemblies, and indeed, 2 years into our work, Anna, the non-verbal Anna, had a star part in one of the school assemblies. All the members of her group were given special permission to sit together rather than in their classroom groups. And at the end, one of them, William, said quite loudly, "Isn't she great, our Anna?" Their shared pride in this little girl was palpable. Anna discovered other children in a setting which I could ensure was not too overwhelming for her. And the other children in the group became incredibly important for her development. They would come to the nursery wall at break times to seek her out. And she soon learned all their names, and she constantly asked her teacher, "When coming?" And she would list the names of the children in her group. This first experience of autism helped me really understand that in order to grow, we all need groups. We need an environment that supports growth for the inevitable times of drought and hostile conditions. Just as in individual development, so it is in the development of ideas, I believe. Opposition to a psychoanalytic way of working came from both within the psychoanalytic community and from outside. Within the school, as I said, initially I was regarded with suspicion, being called the shrink. And I had to prove my resilience by spending the first half term as a relief teacher. Any of you who've been a teacher will know what that's like. And I also had to take playground duty. Over time, I was fully embraced by such generous colleagues. And in fact, during one half term, 2 of my colleagues, without telling me, had, with the head teacher's support, decorated a room at the top of the school so as to provide an appropriate environment for the groups. What else did I learn? I learned that the world of autism, the world of the child with autism, is truly a world apart, and often a cause of considerable distress to their parents and to their siblings. There's not enough time within 15 minutes today to develop these ideas further, but I also discovered something which has stayed with me. I had to learn how to walk in each child's shoes because each child with autism is unique. So no prescriptive intervention, in my view, can be effective. I had to mobilize all my curiosity. Why does he or she do this? Why won't he or she do that? How do they experience me and the world around them? When and under what conditions do they seem to function most optimally? And what conditions impact upon them adversely? I stress the importance of this early experience with Anna, as it taught me to believe in my experience and have the courage of my convictions, whilst also being aware that no one person has all the answers, and so being open to the ideas of others. It was essential for me in learning to be resilient. I did not know when I started out that many people held the view then, as Sarah said, that children with autism could not change. But I learned from my own experience that indeed they sometimes could. When I qualified, Matty Harris continued to be a support and suggested that any referrals of children with autism to the department should come to me. What started as a very slow trickle gradually gathered pace by word of mouth, one family encouraging another family to give us a try, and schools too, who found one of their children seemed to benefit from contact with us, encouraging other parents also to give us a try. One day in the early 80s, I realized I was supervising 7 trainee child psychotherapists, each of whom was working with a child with autism. I began to see patterns in their behavior and became increasingly aware of the importance of adapting my way of working from a more orthodox psychoanalytic approach. I was allowed to set up a seminar, and I'll be forever grateful for this early opportunity. Here, I must mention my colleague, Trudy Klauber. She joined us, and as well as her keen intelligence, she was also generous enough to take minutes of our meetings, and this has allowed us to track our early thinking as it developed. In 1986, I founded the Autism Research Workshop and the Autism Service. We were joined by many colleagues, too numerous to mention here, who've made contributions, major contributions to thinking about autism. But I must especially mention Maria Rode, Dr. Tony Lee, and of course, Anne Alvarez, whose work is already known to many of you. Anne will be describing further developments in our thinking when she speaks. The workshop was initially opened only to people in the Tavistock, but then we were joined by people around the country, by colleagues from abroad, contributing to a really lively exchange of ideas. The work at this time was particularly supported by Dr. Caroline Lindsay, psychiatrist and chair of the department, and by many generous colleagues outside. And here I must mention Teresa Vasilevska, who was an educational psychologist, Joanna Ruggieri, a head of a school, but there were many. The Tavistock was purely NHS in those days, and I was therefore allowed to travel around to other institutions, NHS, hospitals, and so on, sharing our findings and exchanging ideas. Within the workshop, there was a lively, creative atmosphere which allowed for playing with ideas, and we were free to think together about the technical adjustments we had to make if we were really to reach these children. These were based on detailed presentations of the children's sessions. As an NHS department, we were, quite rightly, expected to respond to anyone who was referred to us. And this meant we had access to children of all ages, from the very young to older adolescents. One important discovery was that the earlier we could intervene, the more profound the impact was likely to be on the child's development. However, when some of the children showed signs of improvement, we were sometimes told they must have been misdiagnosed in the first place, a cause of considerable frustration. However, it generated a number of formal research projects with Dr. Lee and Anne, and we measured the impact of assessing the children before, during, and after treatment. And Anne will say a bit more about this. There were many developments over the years, but the one I feel most pleased about was the increasing involvement of our patients' parents. We formed a group for the parents of the children in treatment, together with Trudy, and some of these parents then generously gave of their time in organising a series of conferences beginning in 2003, at which they and our patients were speakers. Our patients' trust in us, their parents and their generosity supported all of our work. And here I would say, and I really emphasize this, that contact with these parents from a wide variety of backgrounds, ethnicities, and religions made so clear that autism is no respecter of social background, ethnicity, religion. It can happen to any of us.
Thank you, Sue. Anne, can you unmute yourself?
Okay.
No.
All right, thank you. Well, I had my first taste of autism on a research project, which I worked on the summer before I came to train in 1962 at the Tavistock. It was a research project for autistic children, and there was no psychotherapy, but they were studying subtypes and differences, and that was a whole interesting subject in its own right. But I continued to be fascinated by them after that taste. And after I came to the TAVI, I stopped working there for about 14 years while I was raising my children, working only privately, although I still taught here. I'm saying here, I'm not at the TAVI today, but anyway. When I came back in the late 80s, Sue and I were both supervising a trainee, Janet Bungener, and she kept telling both of us that we were saying similar things about technique with children with autism. Eventually, we got together with her to discuss a patient and found that indeed she was right. I remember us talking about the fact we had both been discussing the problem of perspective for these children, but we were talking about two different versions of perspectives. That is, which angle you look at something from versus how far away it is. Sue then invited me to join the workshop as co-chair. Another similarity that emerged was to do with the introduction of a more intensified response to what we both saw as the emptiness in some children with autism. This involved a recognition that some of these children had a genuine deficit in interest in or desire for other people or the world. I had on one occasion, that was in 1971, found myself in a state of terrible urgency about the nearness of my patient Robbie to a kind of psychic death. I had stopped work for a few months to have a baby. His mother had had a baby during the same period, that was his first sibling, and I was now only seeing him once a month for reviews. I felt on that day that I was losing him for good. And this was the last session before a 2-month summer break. I got increasingly alarmed, and eventually I responded with great urgency to how far gone he seemed. I put my face in his line of vision, calling his name over and over. He seemed to awaken from a deep sleep or a deep drowning and greeted me with a kind of slow, delighted surprise, as though he hadn't seen me for a very long time. He said, "Hello," really sweetly. Then the next day, he had a breakdown or breakout from his autism and sobbed for a week, telling his parents about a trauma he had had, indeed that the whole family had had when he was 2. I then spent years wondering what I had done in that session, as it seemed pretty unpsychoanalytic. It wasn't neutral, but nor was it even containing, to use the then more modern terminology of Bick and Bion. We're quite familiar with it nowadays. I eventually termed it a kind of reclamation, and others have subsequently pointed out it was a kind of vitalization. I came to conclude that Robbie was not hiding, as I had originally thought. He was lost. He was not withdrawn, as I'd originally thought. He was undrawn. His apparent emptiness was not due to resistance. He really had become empty. He'd gotten much more severely autistic or dissociated or whatever you want to call it during those months. During the same period, it turned out that Sue was making a similar discovery. She was identifying something she was doing to show her autistic patients that the world could be interesting, namely generation and demonstration of the value and interestingness of the world via toys or objects in the room. She was careful, however, whenever I got over-enthusiastic about vitalization, to point out that these more intensified methods could be counterproductive with another type of child with autism, those who can easily feel very intruded upon and are more avoidant. I think Lorna Wigg called them the aloof group. But I'm talking about them as though these were classifiable, separated groups. What I'm really trying to classify here is states of mind, because one child may move between the more empty state to the more resistant state, and they don't stay in these neat groups, as any clinician knows. I think we took great comfort from the fact that someone else was trying to find new ways of addressing the nature of the disorder when the classical methods, although they helped, didn't seem adequate. We came to say that the work with these children needed to be not only psychoanalytically informed, that is working via the relationship, but also, excuse me, but also developmentally informed and psychopathologically informed. It needed to be developmentally informed because the non-autistic part of the personality, the spared function as it's called, often was hidden behind the autism, and it was often very developmentally delayed compared to the child's actual chronological age. My patient Samuel was 3 years old, but his score on the Vineland Adaptive Behavior Scale of expressive communication skills lay at the profoundly low level of 1 month of age. The gap is not always as dramatic as that, but nevertheless, it can be easy for people to confuse this immaturity with the autism itself. Yet these immature moments may be very person-related, and that is the clue that it may be coming from the non-autistic part of the personality rather than the autism. The second issue that was preoccupying to both Sue and me was the problem of how to deal with the autistic, repetitive, often relentlessly repetitive behaviors and interests. Ordinary interpretations and explanations were often not effective when the child was being almost hypnotized by his own bad habits of mind. We're both finding a variety of ways of approaching these, for example, sometimes actively discouraging, sometimes trying to join in with a bit of accompaniment, for example, tapping our feet in the same rhythm just to get noticed a bit. Again, this was not pure classical analysis meant to encourage reflection. We were both aware that these children were not functioning symbolically, and not engaged in symbolically meaningful activities. I was calling them addictive, and Sue pointed out that the child was sometimes simply very stuck. What we both wanted to do was find a way to clear a little space in the child's mind for something new to enter, and it was not easy. A third problem that concerned us, again following from the very particular nature of the autistic condition, is that when we did manage to succeed in attracting the child's attention away from his ritual, he seemed to have no idea what else could be available. In this respect, his lack of resources resembled that of the neglected children, but for different reasons. With the autism, there's a kind of terrible self-neglect as they turn away from the human race. They have little opportunity to interject and take in new experiences. We found that if we left the child to his own devices for that moment, he just returned to the repetitions. We had to very quickly, if we got his attention away from them, offer something else, hopefully enticing enough to grab and hold his attention. I called it being a bit like a traffic policeman, and Sue had a much nicer image, the orchestra conductor encouraging the string section on, for example. Sue has said that when the children did well in our treatment, people often said, well, they couldn't have been autistic in the first place. We were keen to do some research with before and after measures. So I went to see our professor then, Izzy Colvin, or he was a research professor who had joined the Child and Family Department. He was the first of the researchers who joined us. He suggested a single case study with the treatment being videoed. I then did a 4-year study with Tony Lee, as Sue has mentioned, a research psychologist who had joined our workshop and who later went on to train as a child psychotherapist. In the meantime, he helped both of us and many other people at the TAVI to design our studies. He and I developed a series of scales for measuring the child's relatedness or lack of it, and were able to show considerable improvements in that extremely severely autistic little boy I mentioned, Samuel, with the social scale, communication scale at 1 month of age. We measured changes in the number of times the child looked at me and the duration of his glances. We also had raters rate whether the glances were odd or direct. That simplification nearly broke my clinician's heart because Tony insisted we had no space to distinguish between the different types of odd looks, and they were so odd and so different. But for a clinician, nuance is everything. That's what we care about. But I wasn't allowed to differentiate. We also measured Samuel's emotional engagement and level of interest. That study was published, and at present we are waiting to resume the writing up. We were about to start last March before COVID came, to resume the writing up of a second study where we developed a different rating scale, one that measured the kind of interpretation I was making at particular points in time. It shows that over time, I moved up a level from a more intensified, reclaiming, vitalizing level to a more descriptive level, which we think suggests the child was becoming more accessible and reachable. The scale was developed with Tony and VJ Frankie, a Tavistock trained child psychotherapist, who was then an assistant professor at the University of Geneva. The scale was based on a schema I developed a few years before for thinking about 3 different levels of intervention, with patients ranging from being in mild neurotic states through borderline to more autistic or even psychotic or dissociated states of mind. I would love someday, if I live long enough, to go back and look at those looks on those videos, and also to notice the effects of the wrong level of interpretation on Samuel, as opposed to when I think I got it right. He was not able to say so verbally, but he certainly showed me when I got it wrong. He just retreated from a moment of good contact to return immediately to his autistic behaviors. Sue and I still work together, but I'm sure we both also still miss that workshop. It was a very exciting time. I look forward now to hear more about the new developments at the TAVI from Myron and Nahama. And thanks very much for calling us back from the grave.
Thank you, Anne. Myron, over to you.
Sarah, I'm going to speak before Myron. Sorry,
Okay.
I didn't clarify it with you. I apologize.
That's okay. Nechama.
Thank you. So good afternoon, everyone, colleagues. I'm very honored to be here today and have the opportunity to think with you about the history of the work with autism in Tavistock and the way it has evolved to become our current practice in the team. As part of the preparations for this event today, I had the pleasure to reconnect with colleagues, old and new, who were part of this special team since it was established, and to think about the changes we, as a team, have gone through since its beginning. Some of these colleagues are here with us today, so thank you. I would like to think about my talk today as some kind of a bridge from the work Anne and Sue have just described to what we do now and to the work my colleague Myron will present later on. Why did I choose to start with a bridge? Possibly each of you can think for a few seconds of what a bridge means to you. I suppose sitting here today with Anne and Sue feels like a bridge in its own right from the work of the team in the past to its work in the present. When I think of a bridge in the context of the teamwork, I'm thinking, as I said, obviously of a bridge between the past and the present work of the autism and LD team. I'm thinking of changes in the organization, the restructuring of teams, different ways of being commissioned, and the creation of a separate autism team as opposed to the autism workshop, which was based in a generic team. I'm also thinking of changes in the client population. And whereas in the past, the work was mainly with young children, nowadays, we see many children who are transitioning to secondary school and even older, often with the focus of transitions into adulthood. I'm obviously thinking of a bridge between the internal versus the external world, which all of us find difficult at times to bridge, but how do we do it with our clients? I'm thinking of a bridge between the child or the young person and the family. And I'm thinking of a bridge between the child and the young person and its therapist. I'm also thinking of, I think, Sue, you mentioned it, about the bridge, the important bridge between the network and the broader environment. And I'm thinking about a bridge between the different modalities in our team and different clinicians we work together, and the importance of the multidisciplinary team, the multidisciplinary different clinicians we work with. A word which is often being used thinking about any therapeutic work with children and young people on the spectrum and with LD is adaptation. Do we adapt the work? And if so, how do we adapt? Obviously, one can say we adapt with every single client we see, as every person is different. There are also no two people on the autistic spectrum who are similar, so adaptation is part of the therapist-client relationship. We do find, though, that some general adaptations do happen with many clients on the spectrum. On many occasions, we would find ourselves reaching out more, being more active as therapists in terms of our stance, though this may also vary a lot, as sometimes with girls and young women, it is not needed in such a way. They can be very verbal, and the work would be more around emotional regulation, identity, understanding themselves better, understanding others and their responses to them, as well as managing the difficult emotions it can all bring, as social interactions can be very painful and frustrating. In the literature, some may call it mentalizing and developing of theory of mind. The ability to generalize learning and change is something which is debatable in our client population. Can our client generalize from one relationship to the other, from one setting to the other, or from one situation to the other? In my EMDR work with children and young people on the spectrum, I have learned that we often need to process every single trauma that happened as the ability to generalize from one situation to a similar one is often quite minimal. That puts a big question mark on the ability for learning. However, a child who was bullied still deserves some processing of their trauma, even if it doesn't necessarily decrease the chance of them being bullied again. We do encounter often limitations in the ability to relate and think, which demands creativity on the therapy side. However, such an environment of continuous impaired abilities can have a strong impact on our ability as therapists to relate and think, and pose a huge challenge to our team, who mainly sees children and young people who struggle to relate and think. We can often find ourselves doubting our own ability to do it and to help our clients with developing these skills. Which brings me to one of the biggest questions we have with our client when dealing with in the work. What are the expectations of the work, or what some would call the task of therapy? I started my talk today talking about a bridge. There are some bridges we could create, but there are some which are more difficult to cross. In our work, it is also important to recognize what we cannot do and help our clients and the families to accept it and mourn it. Thinking of the current work of our team and the complexity of the referrals we are receiving, it is important for us to be able to keep a mature, realistic position of what it is that we can achieve. We often see adolescents and young adults who have profound challenges and who would need a lifelong support, which our team will obviously not be able to offer. However, the wish that we could do it and the push for it from clients, services, and ourselves is very strong. We can obviously not see every child and young person on the spectrum in Greater London, and even more so, we cannot be the only ones who are in charge of the care. We often get referrals of cases that have been involved with many services and come to us as the last resort. Like many other services nowadays, our waiting list is long, and clients and families can find themselves waiting while experiencing huge distress and challenges. As a team, it can sometimes feel like instead of being able to be a container to these clients, families, and services, we feel at times more of what Donald Meltzer called crostrum. Referrals are coming in, and it is very difficult to work jointly with services, to be clear to services about what it is that we could do and what it is that we couldn't. Often other services disappear very soon after a referral was made, and we can be left in a helpless, lonely place, a feeling which may represent how many of our families are feeling. Also, in the Tavistock itself, we find it difficult to work jointly at times with other teams. It has been easier in the child and family department, but recurrent efforts to work jointly with adult teams have failed. A big loss to our team was when we had to take a decision not to accept over 25 referrals due to limited resources and the lack of ability to work jointly with adult services outside and inside the Tavistock. For those of us who worked in the past in LCDS, the Learning Complexities and Disability Service, me included, it was a big loss. Another loss to us was the constant diminishing of the learning disability referrals we are receiving, which may similarly relate to the decreasing ability to work jointly with other services and the lack of resources in our service. Looking at the future, I would like to see our service being able to serve more in a consultancy capacity, consulting to therapeutic services inside and outside of the Tavistock, as well as to schools, social care, and other systems in client network. Consultancy work can help a great deal also with maintaining services waiting lists. I would like to see us developing the capacity to work jointly with services and not in closed, segregated way, modeling an ability to connect to our clients and to services and not mirroring the at times detached tendencies of our clients. Young people we see often state that the world needs to adapt to them and not them needing to try and fit into the world. Many young people claim that they are happy with the way they are, whereas their system, their families really struggle. I recall seeing a woman who presented with an extreme sensitivity to light. She used to walk into the therapy room and switch the lights off straight on without even asking if I'm okay with it. I saw her for an assessment for group work, and the issue, of obvious reasons, escalated when she joined a group of 5 others who didn't wish to sit in the dark. This raised different questions. Is it only a sensitivity to light and everyone should sit in the dark, or does it represent an oversensitivity to the world and a lack of ability to fit in, or all the above? Does anyone else need to fit in and sit in the dark? And how do you consider individual differences in a group? How do you relate to the other? How do you negotiate it? Do these young people really not feel that they struggle and only others need to manage how to live next to them? These dilemmas are there in our work in individual psychotherapy, psychoeducation, CBT, parent work, and in the group work in our team. We offer support for children and young people themselves, to the families, and in recent times, more and more support to parents, if in the form of a couple or in the form of parents group. Many of our families can feel very isolated and alone in the struggle, and a bridge between parents, if in the couple and if with other parents, can offer crucial and priceless support. There is a lot more to say, but I will pause here and will let Myron take over.
Thank you, Nahama. I think first of all, I just wanted to say thank you to Sarah for being the bridge between Sue and Anne and myself and Nahama. I thought you were gonna introduce me just then, Sarah, and then I could say thank you for being the bridge, but you didn't do that. But you have been a forthright bridge between Sue and Anne and Nahama and I, and it's a real pleasure. I think I speak for both Nahama and myself to be here talking alongside Sue and Anne, whose work is indelibly imprinted in the DNA of our service. I do have a few pictures which I'm going to try and show now, which is always a time of uncertainty. But the first picture I've got is actually a picture that shows Sue and Anne's book, Autism and Personality. And when trainees in psychiatry start on the team, I recommend they read the introductory chapter, because it's an excellent introduction really to the way the team works. And it's a chapter which is also very open to other ideas, other perspectives, kind of later research at the time, around kind of theory of mind, cognitive perspectives. So I really recommend people read this. And the other book I've put up there is really to represent all the colleagues since then that we've worked with, who contributed to this book and to the work of the team. So it's edited, it's called Unexpected Gains, and it's really about the psychotherapeutic approach applied to individuals with learning disabilities, edited by my predecessor David Simpson and also my old colleague Linda Miller. And I know that there's other people who contributed to the book on this at this event today, like Nancy Shepherd, and our COO, I think, Sally Hodges, also wrote a chapter there. I should also, it's not going to turn into an Oscar speech, but I should mention also the team leaders in our time, Sarah Helps, Nina Wessels, and our current leader, Emma Kennedy, who have taken on the rather challenging role of leading a kind of diverse group of professionals in working with this group of children and young people. And multidisciplinary working is particularly important in the field of autism. In fact, it's one of the key messages in NICE guidelines. And in the autism service, we've always been very lucky to have staff who not only have clinical roles, but also roles in teaching and training here. So, and I think because of this, the voice of each of the disciplines in the team has always been very confident, with a very lively interdisciplinary dialogue. And at times, of course, there's kind of tensions and disagreements, but I think overall the effect is really to greatly enrich the clinical work that we do. I also wanted to mention that whilst we're talking today about the work of the Autism Service based at the Tavistock Centre in Belsize Lane, it's important to acknowledge the other service that works with children with autism, which is the Camden Mosaic Service based in Kentish Town. And Camden Mosaic is very much an exemplar for multi-agency working, as the team is integrated in with community child health services and social services for children with disabilities. So Tavistock psychologists, psychotherapists and psychiatrists work alongside speech and language therapists, occupational therapists, paediatricians and social workers in that team. So Camden Mosaic very much shares and develops has developed the Tavistock approach to autism, and the links between our services have been invaluable, particularly when we set up and developed the diagnostic assessment part of our service, which is the part of our team that I'm going to talk about now. The diagnostic service was something that we have developed over the past 10 years in response to increasing demand for assessments of adolescents and young people who have average or above average intellectual ability, but are noted to have social difficulties. And there have been many reasons proposed why there's an increase in demand for assessment in this group, which include the increased awareness of the autism spectrum condition. There's been an extension of the diagnostic boundaries, and some would say that's been an overextension. There is also the increased social demands that young people face in today's world, and also the pressure on resources, for example, in schools, that has led to really this drive to formalise the needs of young people with social communication challenges. So our service predominantly sees adolescents and young adults, and I think this immediately poses a question regarding consent, because sometimes it is the young person who is seeking referral, who's seeking assessment, because they're increasingly aware of their difference to peers, but quite often it's a parent who's noticed this different quite often kind of early in development. Or it might be teachers, or it might be other professionals. And I think one thing we've increasingly realised in our service is the importance of spending time at the outset of an assessment, clarifying the young person's views about autism and their assessment, and think with them about what the benefits might be, and what might be the drawbacks. And some young people are quite clear that they don't want what they perceive to be as a label, stigmatizing labels, and others feel that it will help them understand themselves better. And I think probably most young people we see aren't quite sure either way. They have an ambivalence, and I think this can be very difficult for parents in particular, who've often battled for quite a long time to get a referral for assessment. I think a second issue working in this group is that children who have very clear autism spectrum condition tend to receive their diagnosis early in life these days. And our service, as it caters for the slightly older age group, I think that means that usually there's a reason why they haven't received a diagnosis as of yet. And quite often it's because the signs of the autism spectrum condition are more subtle. Quite often the young person has been able to compensate to a degree due to other abilities, and Sue and Anne have spoken about personality. Or it may be that they're experiencing other mental health issues like depression or anxiety that cloud the picture. And of course, sometimes the issues that they're experiencing aren't actually related to autism spectrum condition, but they have another origin, including depression and anxiety, or other developmental issues such as ADHD. Or it might be the issues they have in relationships are due to the developmental impact of adverse experiences, and in some cases, trauma. So it's a complicated task making a diagnosis, and a task that all diagnostic services face. And the generally recommended approach is as a careful collection of information from parents, from the young person, from their educational setting, regarding impairments the young person is experiencing in social communication and restricted repetitive behaviours and sensory issues. And commonly standardised assessments are used to gather this information, like the 3DI developmental interview and the ADOS assessment. And in our service, we do use these assessment tools to help us make a diagnosis. But at the same time, I think the way we think and talk about the diagnosis is influenced by a conceptualization of autism spectrum condition, which incorporates the psychoanalytic, systemic, and developmental perspectives that Sue and Anne have spoken about, as well as the knowledge and experience of educational and clinical psychologists, social workers, speech and language therapists, and psychiatrists. The neurobiological and organic basis of autism spectrum condition is well established, but there's been continuing debate amongst researchers over decades, really, about what the underlying core difference is at a psychological level. And an idea that's had a lot of traction over the years is that people with autism spectrum condition have a deficit or a delay in the development of theory of mind. Another is that autism spectrum condition is a condition where there's a difference in the processing of information. But from a more psychoanalytic perspective, Peter Hobson, who worked in the adult department of the Tavistock, and Tony Lee, who has been mentioned a lot today, who was a brilliant psychotherapist in our team, have advanced a broader, more relational model in which they propose that in autism, there are barriers to an individual's effective identification with others. And I think the interesting aspects of the theory is it's developmental in nature, and symptoms such as the rituals and repetitive behaviours arise from a primary deficit. And I think that very much fits with the descriptions that Sue and Anne have given about the course of the features of autism spectrum condition. And I think this kind of psychoanalytical perspective also explains the heterogeneity of the presentation. And I think something very particularly salient in Sue and Anne's work is the appreciation of the individuality of each person with autism spectrum condition. And they've written about the importance of personality. And we impress on young people that a diagnosis perhaps describes some aspects of the way they function in the world, but it doesn't describe their totality. Inevitably, in a diagnostic assessment, there's a pressure to collect information on autistic symptoms. However, as part of our assessments, we meet with young people individually with an aim of more broadly understanding their experience of the world and relationships, and also something of their strengths. And in our service, we found projective assessments such as kinetic family drawings and sentence completion tasks particularly useful in this regard. We also pay attention to the young person's context, and we meet with them with their families to explore how their symptoms impact the family and what meaning has been ascribed to them. And one area we've determined we need to explore more is the impact of culture, ethnicity, and race. School visits and consultations provide information on another important context that young people navigate. And we acknowledge that young people are coming to us at a time when peer relationships are increasingly complicated. They're negotiating the hurdles of GCSEs, A-levels, and they're faced with the prospect of what might happen after they finish school. More generally, adolescence is a time when young people are grappling with issues of identity. And we're very mindful of the impact that a diagnosis can have at this sensitive time. The concept of neurodiversity has influenced the way we think and talk about autism spectrum condition in terms of a difference rather than a disorder, albeit a difference that can bring many challenges, but also strengths. We need to acknowledge that the world tends to be organised according to the needs of neurotypical individuals. And we hope that by identifying autism spectrum condition through the diagnostic process, we can empower young people with greater self-knowledge. But we also hope that it's a spur for those around them to make the necessary changes to promote inclusivity. In this way, those with autism spectrum condition can achieve their potential to make valuable contributions to the community and live fulfilling lives. I wanted to end by saying that trainees in our service make a huge contribution to its delivery and development. This is an excerpt from a letter that a trainee educational psychologist wrote to a young person they worked with. And I think it encapsulates what I've said about autism, personality, development, and uncertainty. One important thing you shared was that the diagnosis from the AS team had been useful, and it has been like a piece of a jigsaw to help you to understand one aspect of yourself. I would like to encourage you to keep finding the metaphorical jigsaw pieces, but also to recognize that this is a lifelong task and that everyone is still developing and changing. We can spend our lifetimes finding our jigsaw pieces. Thank you.
Thank you very much to all four of our speakers for what has been a very rich and varied presentation. I would invite you now to communicate with our speakers by either raising your hand virtually, not literally, and I will call on you, or by putting a chat message to me asking a question, which I will can then ask on your behalf. And I can pull together questions if we have several similar ones. So where would we like to start? Nancy Shepherd has a question. Nancy, would you like to unmute yourself and ask it?
Hi. Oh, it says the host is not allowing us to unmute ourselves.
Okay, you are unmuted, so speak.
Can you hear me?
Yes.
Okay. Okay, thank you. What a lovely presentation from everybody. Thank you so much. It's such a pleasure to see everybody together. And I was really thinking, Nakama, about your concept of bridges. It's more of a comment actually than question, Sarah, sorry, but I will be brief. And actually thinking about you when you said, what does the bridge mean? And obviously having been in the services myself for a very long time, I think one of the key things for me and the beauty of the work with young people with autism has been the bridge among the models of thinking. So drawing on different sorts of models to understand what comes to be a very complex conundrum often when we're faced with young people who are facing the difficulties you've been describing. And I was just thinking that I think my career has been very much focused in this area, and that's partly because although complexity is something that sort of is very key, there's also seems to be more than in other areas an openness to thinking in different ways to try to understand the complexity. And I think, you know, Maria Rhodes has done quite a lot of work in our service in Mosaic with very little children and thought about the concept of this cycle of discouragement. And I think when you have such early discouragement in your life, that it kind of helps, it impacts so profoundly on the whole system, that we've been you know, it's so valuable to have lots of different ways of thinking. And I do think that probably the services at the Tavistock and at Mosaic are unusual in the amount of psychoanalytic thinking that we can draw on, or we have drawn on, in understanding that. And I know colleagues in the OTs, the physios that Myron mentioned in Mosaic, value that thinking so much in the early diagnosis when faced with those conundrums. So I just wanted to say that, really, that I think that it's working with people like Anne and Sue and other colleagues that have allowed us to take on board different ways of thinking and bringing it to make a really valuable service for young people.
Thank you, Nancy. I don't know whether anyone wants to respond to that, but I also have a question from Victoria Muschetti, who's asking if we can say a bit more about what the treatment of a neurodiverse young person looks like, and sort of what's different about it to perhaps more traditional psychotherapy treatment. And I wonder if any of you want to respond, maybe particularly Sue or Anne, to that, as well as to what Nancy said.
I think it would be nice to hear from Sue, since she's the pioneer for the workshop. Unmute. Top right-hand corner, unmute.
Thank you, Anne. Well, I'm still so much absorbing all the presentations from people, and I absolutely agree with Nancy. There's been something so marvelous about the opportunity to share thinking. I think what I want to do is sort of respond to something that Nehama said about the young woman who wanted the lights off. And, you know, did everyone have to fit in with that? And I was thinking, one of the big advantages when we can work across the age ranges and when we work with very, very young children, and as Anne was describing, we have so much to adapt our technique. I've got a little girl I'm working with currently who is very sensitive. All her sensitives are hypersensitive. And I was thinking, depending on the kind of subgroup of the child, we really have to work to the level at which they're functioning and how they experience the world. So I had one little boy who walked into the consulting room, he was like this immediately. He was super conscious of the tiniest little sounds, so he couldn't take anything else in. And a little girl with whom I'm working with now, she had a particularly highly developed sense of smell, which at the beginning didn't really make any sense. But I think this way of allowing the child to come in and discover the room and us following so carefully, but actually much more actively than we would with other patients, can bring things to light. And what I think I'm seeing more and more of, and I don't know if the other people would agree, is that a lot of these children, I do now believe, are born hypersensitive. And sometimes they compensate and they can seem extremely thick-skinned. But I think the process of the therapy, because we don't focus on just their hearing or their acute sense of smell, but their entire experience of us and the different ways in which they experience the world. What's extraordinary is that this little girl, after a year of work, her mother was able to tell me that she's lost this acute sense of smell. And to the degree they joked that they used to ask her, you know, whose clothes are these? Those are this. She just knew. But what's happened is her senses are getting integrated. So she knows it's like an alarm system. Her sense of smell was like an alarm system. And as she's integrating experiences from the world around her with these extremely hardworking parents as well, her sense of smell is just taking its place. So it's very responsive to what one of our colleagues said today. And would you add to that? What would you add?
Well, I will agree, as I said earlier, that I agree there is this more intensified. I try not to use the word we act more because it drives our psychoanalytic beloved colleagues mad, because that doesn't sound like psychoanalysis. But I prefer to call it a more intensified technique. But we do have to be hypersensitive ourselves to their hypersensitivity, or to the smaller subgroup who are under aroused and understimulated, and who's like Robbie at his worst when he was, but even at his best, he was pretty dull-eyed. It took a lot to liven him up, but when he did, he couldn't regulate either. So I think we sort of need a much wider repertoire. What I think isn't changed is that the setting is vital, the regularity and the timing of sessions is vital. The intensive treatment is often vital, but you tend not to be able to get it nowadays. And I just wanted, something came up about the difficulty as they get older, and you have to curtail the treatments even at your current lovely clinic at the Tavistock. But what I was wanting to say is, even the Autistic Society has been saying now for about 10 or 15 years, these people need support. They don't call it psychotherapy, of course, need support throughout the lifespan. It's a developmental disorder. There are crises at every developmental point, and one day let's hope there will be that support. I mean, some people do keep these people in treatment for decades and do not and should not apologize for doing so, because the families use the support. I mean, I won't tell you how many decades I kept Robbie for, and a few others, and the families were very, very grateful. And it supported them through these changes. And Valerie Sinison has written about the painful question of anniversaries and birthdays for learning disabled people, and how painful it is for the parents that they're not meeting current standards of chronology. But there are also many new crises when they realize they're not going to be able to get a girlfriend or find a flat share or whatever, and they need us. So one day I hope it will happen.
So we've got a lot of questions, really all asking why autism seems so much more common now than it was, and also asking about the sort of crossover with trauma, with early trauma, and also with ADHD, but particularly with trauma, and wondering, I suppose, I'm wondering whether those two things are connected, whether we're diagnosing autism more because some of the people that are being diagnosed, maybe their difficulties are about other things, and particularly perhaps about early trauma, and wondering what all of your thoughts are about all of these issues.
Could I say something about early trauma? I do want to really underline this, because my experience with parents is that often parents, I think many of the parents I've seen over the years are heroic, but they often feel very, very guilty. And certainly when I started, there was an enormous shame in having a child diagnosed with autism. I think there is less shame, thank God, and so there should be. But I also want to emphasize here that when we speak, or when I speak of trauma, and Anne does, and our other colleagues must say if they agree, I don't always mean trauma with a capital T. I think it can be a number of cumulative traumatic experiences which in a more resilient child might not cause them to either withdraw or adapt in unusual ways. But it is terribly important, because it can happen to any of us. You can have a family where, the family move house, common enough experience, except we all know it drives us a little bit crazy. But if that happens at the same time as mother or father loses their job, or a parent's parent dies, or something, we all know we've got less resources at moments like that. Sometimes you get cumulative small don't say small in them, they're not important, but they're not always earth-shattering ones. And people often don't realize that that's what they've been through. And with a hypersensitive, hyper-vigilant kind of child, they don't have a filter. So I just wanted to make that point about trauma.
Thanks, Sue. Myron, you were going to say something, and while you're saying something, I have a question about pathological demand avoidance, which I feel has your name on it.
Okay. Just yeah, on the subject of why more people are getting the diagnosis, I think there has been an extension of the diagnostic category, maybe not in DSM-5 kind of formal terms, but certainly the way the diagnosis is in practice, how often we're making a diagnosis. I can certainly think that there's people who get, I give the diagnosis to now that maybe I wouldn't have done 10 years ago. And I think there are some good reasons for that. But I completely agree with Sue's point about, I suppose, the interplay between genetics and experience, really. And it's interesting. Ailish Kennedy, I think it's here, our research lead, sent me an article yesterday from a researcher, probably more in the kind of biological vein, talking about how actually we should think about autism differently as a genetic susceptibility, and then the pathways determined by experience. And to me, that really seems like that's research catching up with what clinicians like Sue and Anne observed many decades ago. And I think that's what we see across the field, really, that there is development and change over time. That was what you describe in your book, and now it's just being formalized in terms of people studying people over their lifetime. And I suppose I just wanted to add a point about sensitivity. I think it's interesting that, again, sensory issues have only recently made it into diagnostic criteria, but in many ways this may be the core issue for many people on the spectrum, this kind of hypersensitivity or underreactivity. And then you can see how the subsequent kind of social communication issues and restricted repetitive behaviors arise from that core issue. So yeah, sensitivity is something we should think about more.
I also want to talk to the connection between trauma and autism. I mean, Myron, you still have the question about the, your question that Sarah was saving to you, but maybe you can respond after.
Dodging it.
I was giving the opportunity. I will come to it when you ask me it.
I agree very much with what you said, Sue, about trauma with capital T, with lowercase, obviously, that it is small trauma, that things can be experienced, the small things of life, because of the lower ability of resilience, can be experienced as very big. And I was talking a bit about it when I was mentioning the EMDR work, and how someone can come after having an unpleasant experience, with the teacher saying something to them in the class, which can be very unpleasant for all of us. But to them, this is something that they don't have any ability to cope with. But I think, kind of thinking a bit about what you said, Myron, about the diagnosis and how do we know how things have started. And, we can try and do a very detailed history taking and thinking about early step and pregnancy and everything, but sometimes we will not be able to know. And I actually just came from a session with a young woman who, in her case, it's very much this debate, because, when she was little, she was left for days outside alone because her mother was not able to manage her. And one may wonder, was her mother not able to manage her because she was so difficult? And then, because she was difficult, the mom was not able to manage her, then it became worse, which is a bit the work that you may do sometimes with a very young child who can be hypersensitive. Or was it something which was more originally to do with the mother struggling and the child, you know, responding to that, which would be more the trauma part of it. And often in our work, we will not know. And, you know, she may be both on the autistic spectrum and have complex trauma, and she may be either, but, you know, sometimes it doesn't really matter when we see a person. What matters nowadays often is which service will they be able to access to, which is often an issue with diagnosing. But, you know, I think these are daily questions we are coping with in our work in the team.
Mm-hmm. So the question that Myron dodged was about pathological demand avoidance and what you think of it, I think, as a sort of another diagnosis or part of autism or not, or what does it all mean, Myron?
Okay, so now you've asked the question, I'll answer it. What do I think about pathological avoidance? I think it's important to keep an open mind. It's not, because it isn't formally in diagnostic classifications, it's not a diagnosis that we tend to formally make in our service, but I guess it describes a particular profile. And I guess, I mean, all diagnoses really are defined according to particular behaviours, and certainly for young people on the spectrum who find demands presumably very overwhelming, and therefore it's kind of difficult to you know, for them to comply. Maybe that's part of the kind of hypersensitivity, but there may be other children who are refusing demands for other reasons. They may get other diagnoses, for example, you know, oppositional defiant disorder or a kind of ADHD kind of picture. So I suppose it's thinking, you know, when we do our diagnostic assessments, we try as much as possible to provide a more general formulation, because a diagnosis in itself doesn't really tell you much, and that's how I kind of treat pathological demand avoidance. I don't think the name in itself is quite stigmatizing, really, to put pathology in a diagnosis. But we do sometimes say that, you know, it has similarities in this profile that has been described, and there's people at King's who've researched it. So I think it's something that we should definitely pay attention to. And, you know, who knows where things will go, whether we'll find biological similarities between PDA and ASD as well. So I certainly don't dismiss it, but it's something to think about. Is that
So I have a lovely communication here from Mariangela Mendez, who says, lovely to be here with you all, and so many bridges in memory since the original workshop. And she wants to know, 1, how has the work with infants at the risk of autism been developed? 2, how have you been linking up with the demand for behavioural approaches, which at least here in Brazil have been very high? And 3, how about some online autism international workshops from time to time, with the very rich model of discussion of detailed clinical material that Sue and Anne so wonderfully pioneered? All big questions.
I'm happy to answer about the links with more behavioral work. I will leave to you to answer about the work with infants. I think this is behavioral work, or you know, how do we integrate it in our work is a big question in our team, and I think in Mosaic they are doing it more than we do. I think there are different reasons to that. I suppose method like PBS, positive support behavior, and the more strict behavior approaches are methods which are being offered often in CAMS across the board. And sometimes referrals which come to us, these are referrals which this has often been tried already and didn't work. And I'm not saying it didn't work because it doesn't work, but that in this case, it didn't work. We often try and offer both and think about what will be best. And I have in mind a recent case we are dealing with in the team where parents are receiving non-violent resistant in CAM service, and we think together with school one of my trainees think together with school about the positive behavior support, and someone in our team is holding the parent work in a bit more of a psychoanalytic perspective, which to us is great, and it's a great ability to you know, use different approaches. I think for me, every time when I see someone, if it's for any of the third wave, you know, CBT approaches, or also for EMDR, I think I will always have in my mind the psychoanalytic concept at the back of my mind, because it gives me, it contains me and gives me a bit, you know, it gives me some perspective of thinking. But I think sometimes skills and you know, more of a hands-on technique are crucial and really, really important for the daily functioning of a child. And I think we are very lucky in our team to be able to combine and offer both.
Sue, Anne, do you want to say something about any of those points?
And do you want to? I want to say something about pathological avoidance syndrome, but because I worry about parents. Anyway, so maybe we should respond to the previous question.
We don't have very much time. Can you
No.
say that
I'll say
quickly?
it very swiftly.
Yeah.
I would hate parents to think that I and others think that all of the children are just extremely sensitive. Because when you live with them, some of them are right little toughies. And when we work with them, boy, can they be. Some of them are sort of more like 10-ton trucks. And underneath, we usually find sensitivity. But some of them, you really have to, the first thing one's having to say is boundaries, boundaries, limits. So I wouldn't want parents to think that I'm always thinking here's a sensitive, you know, creature who's found the world too tough. Sometimes they absolutely rule their families. And sometimes they need a lot of help in the therapy, and their families need support in being able to say, you know, enough, there are other people in the world. And I think it's a bit linked with that diagnosis. And I agree, I don't like it either because it's pathological. Can't say the word.
Apologizing.
Thank you. That one. But I might want to say something about, you know,
Yeah. We don't have a lot of time left to talk. The subject of babies is fascinating and needs a whole presentation, really.
doesn't it?
Oh, you're muted still, Anna. Yeah.
And you need to unmute.
Sorry, just to say that Sue and I have done a lot of work independently and together with mothers and babies. And of course, Maria Road has been doing a lot more. And it's so important. And it you know, it's more effective because those neuronal pathways are more plastic at that point. And it's wonderful work. And we all love it.
Yeah.
Trudy is reminding us to say something about relationship-based approaches and new research in that area around relationship making difficulties. Mohammed, have you got any final words on that? We're
yes, that's a big topic. I suppose, you know, the way I see our work, it's all about relationships. And, you know, it's probably quite related to what I spoke about the bridges. You know, how do you make the bridge, the relationship? And I don't know if it truly meant more than, you know, kind of the intersubjectivity or this kind of, you know, how one impacts the other, because, you know, there are different ways to think about these approaches. But I suppose a lot of what Sue and Anne said about the being very sensitive and kind of bringing yourself maybe in a different way. This is, to me, you know, it sums it up. Maybe what psychotherapy later on for older children and adults would be about these approaches, but I'm not sure truly this is what you meant. So I'm saying something very general, but, you know, clearly we need to have another event like this and think more in depth about it all.
Yes, because I'm afraid we are going to have to stop now. We've come to the boundary. In fact, we've crossed it by 2 minutes. So I'm going to say thank you very much to all 4 of our speakers today. And thank you all for coming and being part of this event. And I'm sorry that it feels so short. I wish we could carry on. But hopefully we will have other opportunities, taking into account what our Brazilian friend said about the possibility, I think, via Zoom of being more connected internationally.